In this video, I'm going to talk about the clinical application of different cholinergic medications. So acetylcholine affects both the autonomic as well as the somatic nervous system. So you can notice that there are two different receptors to acetylcholine. These include the nicotinic as well as the muscarinic receptors. So nicotinic receptors are being used in all preganglionic receptors. So here you can see that all of the preganglionic receptors are made of the nicotinic receptors. And then the parasympathetic nervous system has muscarinic receptors in the postganglionic neurons, and a sympathetic nervous system, on the other hand, has both the muscarinic as well as the adrenergic receptors in the postganglionic neurons. And then the adrenal medulla as well as the neuromuscular junction of the skeletal muscles directly innervated by the nicotinic receptors. So the effects of different medications depend on how they affect the concentration of acetylcholine. So medications like acetylcholine agonists, for instance, the acetylcholine esterase is the enzyme that will break down acetylcholine. So if you provide acetylcholine esterase inhibitors like neostigmine, it would increase the concentration of acetylcholine, and it induces the effects that are listed here, including meiosis, for instance, constriction of the pupils, decreased heart rate, bronchoconstriction, diarrhea, urination, CNS excitation, and then increased secretions like lacrimation, sweating, and salivation. Medications, on the other hand, that will decrease the concentration of acetylcholine, like for instance atropine or Jimson weed, which is a plant that is high in concentration of atropine. They will have a reverse effect to what I've just discussed earlier, including mydriasis, which is the dilation of the pupils, increased heart rate, vasodilation, constipation, urinary retention, delirium, and decreased secretions. So next, I would like to go over the function of the cholinergic drugs, starting with the ones that are acting on the acetylcholine receptors. So there are two different drugs that we have here, the ones that are acting on nicotinic versus the one that are acting on muscarinic receptors. So nicotinic antagonists as well as the nicotinic agonists like the succinylcholine, they're both causing muscle relaxation. Some nicotinic antagonists like atropine, these are non-depolarizing muscle relaxants which function by antagonizing nicotinic receptors. On the other hand, succinylcholine is a depolarizing muscle relaxant. And the way it works is that it overstimulates the nicotinic receptors, as a consequence of which it will cause flaccid paralysis. But before it does that, it will first cause fasciculations of muscles, and then later on it leads to flaccid paralysis during phase 1, which is the depolarizing phase. And then following that, there is phase 2, where the end plate is repolarizing, and thus this is referred to as desensitizing phase. So if you're providing these patients with neostigmine, what happens is that neostigmine increases the concentration of acetylcholine in the synaptic cleft. So it will augment phase 1 while it will reverse phase 2, or the desensitizing phase. The next two groups of medications that I'm listing here are acting on muscarinic receptors. So here we have muscarinic agonists like pilocarpine, which is used for the treatment of glaucoma, methacholine, which is used for detecting asthma. So what you will do is that you will provide patients that you suspect may have asthma with methacholine, and if it exacerbates their condition, then that helps with the diagnosis of asthma. And the way I memorize it is that methacholine, so metal and chol, are bad for asthma. So metal and chol are bad for asthma. It would exacerbate condition of patients that are predisposed to asthma, and so it helps with the diagnosis of asthma. And then the last medication is vesamicol, which is used in patients with urinary retention or ileus to help them with their bowel movement or with urination. And again, the way I memorize it is that vesamicol, so Beth makes me think of bathroom. So vesamicol makes you to go to the bathroom. The next classes of medications are muscarinic antagonists like atropine or tropicamide, which are causing mydriasis and cycloplasia for ophthalmic purposes, ipratropium, which is used for the treatment of asthma and COPD, scopolamine, which is used for motion sickness, so it prevents nausea in patients that are developing motion sickness. Benztropine and trihexyphenidyl is for the treatment of Parkinson's symptoms in patients that have Parkinson. For instance, both of these medications can help with the resting tremor in patients with Parkinson's disease. Another classes of medications are glycopyrrolate or dicyclomine, which if you use parenterally, it will decrease the airway secretions. On the other hand, if you use them via the oral route, then it would decrease drooling and prevent peptic ulcer. The next class of medications are acetylcholine esterase inhibitors. So as I discussed earlier, acetylcholine esterase is the enzyme that will break down acetylcholine in the synaptic cleft. So if you provide patients with acetylcholine esterase inhibitors, then there would be an increased concentration of acetylcholine in the synaptic cleft. And then the short-acting version is called edrophonium, and this medication is used for the diagnosis of myasthenia gravis. So if a patient presents to the office with the muscle weakness and you're suspecting myasthenia gravis, what you can do is that you can provide edrophonium. If the symptoms improve, then that confirms the diagnosis of myasthenia gravis. On the other hand, let's say that you've already provided patients with myasthenia gravis with neostigmine or pyridostigmine, and then they're still complaining of weakness. The question is, have you provided enough medication, or have you overdosed them, which could have caused the weakness? So what you can do is that you can provide them with edrophonium on top of the medication that they're taking. If it improves the symptoms, then it means you haven't given enough medication. However, if it worsens the symptoms, then it means that you've overdosed these patients with the neostigmine or pyridostigmine. Another group of the acetylcholine esterase inhibitors that we have are tertiary amines like physostigmine, which is used for the treatment of glaucoma. We have also organophosphates like ecothiopate, which is used for the treatment of glaucoma, and then malathion or parathion, which are insecticides and can cause increased acetylcholine like salivation, excess sweating, and meiosis of the pupils. And then finally we have the nerve gas sarin, which causes the aging process by permanent inactivation of the acetylcholine esterase. So you have a certain amount of time to antidote these patients, otherwise aging will occur and then there would be a permanent inactivation of acetylcholine esterase. So if a patient presents with a nerve gas toxicity, like for instance victims of the chemical warfare in Syrian civil war who presented with runny nose, pinpoint pupils, nausea and vomiting as well as drooling, then you will have to give them atropine and parasympathetic to reverse the effects before aging occurs. And then finally we have lipid soluble like donepezil, which is used for the treatment of Alzheimer's disease. The next classes of medications affect the reuptake or the vesicular transport, and these medications include hemicholinium for reuptake and vesamicol for vesicular transport, and both of these medications are used for research purposes. And then finally we have vesicular release inhibitors like botulinum toxin, which can be used for the treatment of dystonia or muscle spasm. So if there's a patient that has muscle spasm in the neck that cannot turn the neck, then you can provide injection of botulinum toxin to help resolve the muscle spasm or dystonia. And then it's also used for the cosmetic purposes to help relieve the facial creases. So here I've provided you with an image that shows the function of hemicholinium. So here we have the acetylcholine in the synaptic cleft, and it's the acetylcholine esterase enzyme that breaks down the acetylcholine. The choline will be reabsorbed, and this is actually the rate limiting step of acetylcholine synthesis. So what hemicholinium does is that it inhibits the reuptake of choline. So hemicholinium inhibits the rate limiting step of the acetylcholine synthesis. And then we have the vesamicol, which prevents the incorporation of acetylcholine into the vesicles. And finally we have the botulinum toxin, which prevents the release of the acetylcholine from the vesicles into the synaptic cleft. Now earlier I mentioned that Jimson weed has a dangerous levels of atropine, and thus patients that are consuming this plant are presenting with dilated pupils, and you will have to treat them with the acetylcholine esterase inhibitors like for instance physostigmine. The other term that is used for toxicity with this drug is called belladonna, and belladonna means beautiful lady. And the reason this plant is given this name is that it causes dilated pupils, which makes the lady looks beautiful. In addition to these medications, you should also know that there are other medications that their side effects have anticholinergic effects. For instance, the tricyclic antidepressant medications like norepinephrine or epinephrine can have anticholinergic effects. Other medications that have anticholinergic effects include the low-potency first-generation antipsychotics, like for instance chlorpromazine or thioridazine, as well as the first-generation antihistamines like diphenhydramine and dimenhydrinate. And thus these medications also have antiemetic properties because of their anticholinergic side effect. And that concludes our discussion.